CNS infections. The good news is we talked about a lot of this stuff in other classes, so it should go pretty quickly. The lecture objectives, there are quite a few of them here. Basically, we're only going to be talking about meningitis and encephalitis and brain abscesses, so there's not a lot of topics, it's just some things we need to cover related to them. Meningitis is sort of a misnomer because it doesn't just involve the meninges. It involves everything in the calvaria, including the brain. So it's sort of a misnomer. The two types of meningitis we discussed, one is bacterial and the other is aseptic, which is also a misnomer because most aseptic meningitis is caused by a virus. It's not truly aseptic. The only reason they call it aseptic, and I don't know if I mentioned it the other day, is because the bacteria didn't grow. But it is due to an infectious agent. Also included in aseptic meningitis are all the fungal infections and infections from agents like yeast, and we'll cover these later on. Okay? The good news about the viral meningitis, though, is it's self-limiting. So you don't need to have them on acyclovir or anything like that unless it's specific to herpes. So both viral meningitis is not due to herpes, it's due to common cold type viruses, adenoviruses, enteroviruses, that sort of thing. Risk factors for meningitis, hematogenous spread is probably number one. So hematogenous spread from some other infection, like a pulmonary infection, that gets into the circulation and makes its way to the CNS. Parameningeal focus, foci, we talked about from things like abscess teeth or ear infections, sinus infections, anything that can involve really the head. And then mechanical things like head trauma. If you do a neurosurgical procedure, obviously you're at risk for meningitis. Okay. Meningitis etiology changes with age. So you need to pay attention to this. In 0 to 3 months, group B strep is probably the most common cause. And that's why during the prenatal visits, at some point in the last trimester, they will, during a pelvic exam, you culture the vagina for group B strep. If it's present, then you treat it during delivery. You give them a whopping dose of antibiotic during essentially right at the start of the labor and delivery to prevent this complication. The only thing it's for is to prevent postpartum meningitis in kids. E. coli, because of the contamination of the proximity of the rectum during the birth process, and then, of course, viruses. Cytomegalovirus is big in little children, and HSV, and that's why if there is an active HSV infection in the birth canal, it's a C-section to prevent HSV encephalitis or meningitis. It's not a question, it's a C-section. Okay? And enteroviruses from the gut. When you get to 3 months to 3 years, Neisseria meningitidis becomes a key player, as well as strep pneumoniae. We'll go over vaccinations later on, but you target strep early on in the vaccination process to prevent meningitis in little kids. TB, it's probably pretty rare, but it's listed in this age group. When you get to children and young adults, strep pneumo and Neisseria, again, are your big players. The viruses change a little bit. you're starting to pick up respiratory viruses like the adenoviruses. And then you get the bizarre things like the fungal. I've never seen a fungal, a protozoan meningitis, but I've seen a ton of bacterial and more tons of viral meningitis. The classic triad is fever, stiff neck, and altered mental status. Well, it doesn't help you distinguish between bacterial or viral. You can improve the probabilities if you pick up headache in there as bacterial, but that's not a given. Bottom line is, this is not a triad that you should believe in. You should view these as symptoms and signs in order to begin the process of ruling out meningitis or encephalitis, which presents the same way. Now here's the problem, even when you get with the little neonates here, the neonates can't tell you that they have a stiff neck. They can't tell you that all the stuff on the right, they can't tell you all these things, and you can't demonstrate it. What you have to do is use certain maneuvers in order to, or in observations, in order to raise the index of suspicion of meningitis in a little child. If you get a 6-month-old, you can't say you have a stiff neck. It's not going to work. So there are different maneuvers you can do. One of them is you want to see if they will move their neck or if they have nuchal rigidity. If you're the little child and you're the mother, I pick you up and hold you here. What are you going to do? You're going to turn around to look for mom. So that is one of the best things you can do right there, is to make the child rotate their head. The other thing is the fontanelle. It says a bulging fontanelle. Fontanelle, remember, we go back to Bregman and anatomy. See, everything goes back to anatomy. It closes at about the age of 1 year. You can just put your fingertip in it at 1 year. So if you're going to use the fontanelle as a symptom or a sign, they need to be probably less than 8 or 9 months old. Maybe even as young as 6 months. Otherwise, the fontanelle is not big enough to appreciate any bulging. But you need to note that in your chart. Now, bulging fontanelle is indicating increased intracranial pressure. The sunken fontanelle indicates dehydration. So when you're doing an exam on an infant, make sure you put in your note, when you do the HEENOT, fontanelle flat, or fontanelle bulging, fontanelle sunken. Okay? It's a clue as to whether or not something's going on. Koenig sign and Brzezinski sign we've been over actually with these exact same pictures. So make sure you know these. Nuchal and spinal rigidity is also what you see in these kids where they just don't want to move because of the pain. Diagnosis of meningitis, CBC is not going to help you. The CBC, though, will tell you if there is infection, sort of. I don't know, I think I remember one of your lecturers telling you that the CBC is almost absolutely worthless. Has somebody told you that?
Maybe that lady?
Yeah, the CBC, you can get fooled so badly, so many times, because it's so non-specific, it's almost worthless, especially with something like meningitis. Meningitis, you're talking about a process going on behind the blood-brain barrier, and you're examining the blood, so there's an issue here. You can use it to help you in your investigation, but you cannot use it to rule out anything. Right? Blood cultures, though, are helpful, but they're going to take 48 hours before you'll know anything. Over on the other side, CT, if you're going to investigate, trying to rule in or out meningitis, go ahead and get the CT. Go ahead and get the CT to confirm there's no space occupying lesion or no indication of increased intracranial pressure. And that's not gonna help you a whole lot if it's a slight increase in intracranial pressure, but if it's due to some mass lesion, you rule it out there. Then LP, that's your diagnostic tool right there. The LP, when you do an LP, and you're going to learn how to do that in December, when you put the needle in, it has a three-way stopcock on it. So what you do is once you get it inserted, you put a glass cylinder on it that's graduated, and you put that on there, open the stopcock. And the pressure inside the CSF will go up on that cylinder, graded cylinder. Remember I said yesterday it was 10 to 25 millimeters of mercury, right? You can convert that to water. I think it was 10 to 25. I don't remember the units. That's what you're looking for here. Be within that range. You measure that. That's the pressure. You measure the opening pressure. When it goes up, how high does it go? It'll come down a little bit as it equalizes. But that opening pressure is what you're looking for. In meningitis, it's going to be higher typically, especially if it's bacterial meningitis. Then what you do is you'll have 3 test tubes right there. You take the measure tube off, and you take the stopcock and you fill each of those 3 tubes. The first tube, since you go through the skin with the needle, the first tube is going to be the most contaminated. It's the third tube that gives you the most sensitive information. So the things that you look for in an LP, one is you're going to do a CBC on that fluid. You can just run it through a culture counter just like you can blood. It's the same process. It'll give you a white count, and neutrophils, lymphocytes, and so on. Then you're going to do a gram stain of the fluid. And that will tell you right then if you have bacterial meningitis. They'll tell you gram positive, gram negative, cocci, or the other thing, the rods. That will sort of point you into, well, is it strep or is it E. coli? What? If there's nothing on a gram stain, then you're probably looking at viral. You correlate that with the CDC. And the third thing is a culture of this and sensitivity. The culture will you'll get the culture results back tomorrow, 24 hours later. They'll tell you pretty much what the bug is 24 hours later. 48 hours after you submit it, they'll tell you what the sensitivity is. None of that is really useful. Regarding the patient sitting right in front of them. You can't wait 48 hours to treat them. You can't wait 24 hours to treat them. You need to know right now, today, does the gram stain show anything, and what's the CBC count? X-rays, if you suspect other sites, and an EEG, if you're considering, if you're having to deal with an altered mental status, a coma, lethargy, seizures, anything like that, anything that would indicate I need to take a look at the brain itself. LP is listed here. Remember how to do, I think we talked about anatomy, essentially how to do an LP. Get in a fetal position. You can do an LP sitting up, but it's easier if the patient's lying down. You feel the tops of the iliac crest, go across here, and find the interspinous space, and that's where the needle goes. Okay? This highlights the issue of doing the CT first. We don't want to wind up with a transtentorial or uncle herniation. Now here's the thing regarding CTs and LPs, is the thing that improves outcome the most in meningitis is early antibiotics on board. Now the general rule that you're going to hear time and time again is if you start somebody on antibiotics, you can't do a culture and a sensitivity after you started them on antibiotics, because it messes up the ability for the bacteria to grow, and you can't do a sensitivity on an empty plate. However, the convention when you're dealing with meningitis is as long as you get that CSF within 4 hours of starting antibiotics, you're good to go. So it is worth going on ahead. If you know you're going to get the CT and LP within 4 hours, go ahead and get that IV started and get an antibiotic rolling. And the antibiotic you're going to see here in just a minute that you want to get rolling first is a 3rd generation cephalosporin, intravascular, and that is ceftriaxone, Rocephin, ceftriaxone. Here's a nice table that shows you the different types of CSF results. Basically what we have here is, here's your normal, and there's the pressure right there. That's water, I think. The 10 to 25 is mercury. This is water. So if you look at bacterial CSF, or for bacterial meningitis, the opening pressure is going to be markedly elevated. Viral, not so much so. If you look at the other two things, three things. One is the appearance. If it's clear, it's an indication that you're dealing with a viral meningitis. If it's not clear, it's not viral. Glucose and protein are your other big things. Bacteria metabolize glucose, so it will almost uniformly be down, decreased. Viruses uniformly do not metabolize glucose, so it's normally normal. It may be decreased because of the inflammatory process and the presence of inflammatory cells utilizing glucose, but the virus itself, no. The protein count goes up with bacteria, not so much so with viruses. There is protein with viruses, so that's why it gives it mildly increased versus big time increased. And then the white cell count, unfortunately, is not very useful. It just tells you there's meningitis, but it doesn't distinguish between bacterial and viral, because you can see there is quite a bit of overlap between the two. The predominant cell type is an issue, SEGs versus lymphocytes, but I wouldn't hang my hat on that. Basically what you're looking at is the pressure, the color or the clarity, the protein, and the glucose. As I said, the CBC just says you have meningitis. Treatment for markedly increased intracranial pressure, the two things that you're going to be dealing with are steroids, dexamethasone, and mannitol. Mannitol is sugar, and what you do is you give it IV, and it raises the osmotic pressure of the vasculature so much that it pulls fluid from the cranial vault back into the vascular system, dropping intracranial pressure. You never give mannitol unless you're in an ICU, the patient's in an ICU at a tertiary care hospital and being taken care of by an intensivist. Mannitol, you know, ever since I was a student, mannitol for increased intracranial pressure. Well, that's what you do, but there's so many complications with mannitol and the ability to kill somebody that that needs to be done by an intensivist. And They need to be on, you can start them on the dexamethasone, but they need to be on a helicopter to Wichita, OU, or Dallas.
Is there like a range for, so I'm guessing that one of the major concerns would be hypertension, yeah? You said that mannitol pulls fluids back into the vasculature system.
Oh yeah, you're not worried about hypertension with this.
Is there like a cutoff though, like?
What you're worried about is the CNS effects of mannitol. You essentially squash the CNS. I mean, it really should only be given by neurologist or intensivist. And it only should be given in an ICU, not the Blackwell emergency room. Okay. Here's the treatment here. Now, if you'll notice here, we've got it divided between neonates and children and adults. The commonality between the two, and there are differences, vancomycin in kids and adults is not used in neonates. The commonality between the two, though, is that third generation cephalosporin. And again, it is rocephin, ceftriaxone. What do you do? That's a good question. What do you do if they're allergic to cephalosporin? Wow. I don't know what the second line treatment would be there. If they're allergic to penicillin, I would still give them rocephin. You know, there's only about a 15% crossover there. I'd still give them rocephin. If they're anaphylactic to penicillin, I'd be on the phone with an infectious disease doc. Probably what I'd be doing. Because you've got to have something, you know, there are drugs that concentrate in certain parts of the body. Rocephin concentrates in the CNS. That's why you use rocephin. Bactrim concentrates in the bladder. That's why you use it to treat UTIs. So I'd be calling an ID doctor. Prevention, immunizations. Right now, strep, pneumo, and H-flu are part of the childhood immunization schedule. You know, in addition to, especially with H-flu, essentially eliminating epiglottitis and markedly decreasing the incidence of, between strep pneumo and H-flu, otitis media. It's meningitis you're after. Really, that's the thing. That and croup is what you were after by creating this vaccine. When you get into a herd type environment, then Neisseria meningitidis is, you should do that too. Is that required by you? Do we require that? Yeah, you don't want to get out there in some rotation because you're going to run into people with meningitis. Okay. But in case I forget about it, meningitis, no, it'll come up. It'll come up. Okay, complications of meningitis, there are quite a few. If you don't get taken care of early enough, the incidence of death is pretty high. 1 in 4 people with strep pneumo meningitis will die. That's pretty scary. Neisseria meningitidis, 10%. You get in a dorm where this stuff, suddenly somebody has meningitis due to Neisseria, and it goes viral. It goes back, it spreads. That's bad news. 1 in 10. That would be hard to explain to for the PR people to explain, hey, come to our university. Only 10% of you will die. Yeah, here it is. Okay, so here's the thing. It's part of your normal flora for most people. It's only when you have illness or an opportunistic way to get it from your respiratory issues into my CNS does it become a problem. in the general population, you're talking about like 10%. But when you get into situations where you contaminate each other, it goes up, like military barracks or dorms, as much as, what does it say, 60% here? 60, 80%. So, and it's not that 60 to 80% of you will get meningitis, it's 60 to 80% of you are exposed to it because you live in such a confined place. It's like staph infections go rampant in places like dorms because of the proximity and the, so that's it. The modes of infection with Neisseria have to do with respiratory droplets. Sneezing, somebody without any problems sneezes, and you already have a rhinovirus, you already have a cold, you walk through that sneeze cloud, and now you've got Neisseria on board that's dealing with a inflamed and porous mucosa. Next thing you know, you're the one with meningitis. If you're the one with meningitis, that means that everybody around you that's in your close circle needs to be treated. Needs to be treated. The invasive disease likelihood here, of course, smokers. Smokers is always the answer if it's something bad. The signs and symptoms of meningitis are the same as they are with all other forms of meningitis, with one exception. The exception is the presence of a petechial rash that occurs. Usually the younger they are, the more frequent the rash is. It's one of these rashes on the palms and soles. And what it is a extravasation of fluid. They're leaky vessels. And you wind up with blood outside the vascular space. And they are purplish lesions, they're macules, they're flat, and they can appear as little dots, petechiae, or they can grow in more serious disease to be more like patches. So as you see here in this slide, this little poor child here is just, the rash is just overwhelming. Now, one of the complications, of course, is Waterhouse-Friderichsen syndrome. I think I mentioned that when I was talking about adrenal glands and Neisseria being a cause of that, as well as trauma. But here's the kidney, there's the suprarenal glands on each side, and you can see they're just little bags of blood. That's all, it's just hemorrhagic blood, is all it is. Septic shock, DIC, these are things that obviously can happen. So prevention, vaccination. Definitely vaccination. If you are one of those people that are exposed, then the prophylactic treatment is pretty easy. So if your family member comes down with Neisseria, then just give everybody in the family one Cipro and you're done. Okay? And little kids that can't take Cipro, then you can't give Cipro, you can't give a fluoroquinolone to somebody younger than about 17 because it closes the bone inflates. Then you want to use IV Rocephin or IM Rocephin, not IV. You can use IV. Okay. I had a call the other day from some law student here on campus or downtown. He was working with some law firm, and one of the lawyers came down with meningitis. And he called and said, what do I need to do? Well, there are two things you need to do, there are a couple of things you need to do. One is, and this guy knew absolutely nothing, and when I told him what to do, he didn't call me back, so he's either past the critical period or he's dead, one of the two. First thing you need to do is, how close is your contact? If I'm just walking by Nathan and he winds up with Neisseria meningitis, I don't need prophylaxis. he and I go camping, or if something weird like that, you know, where I'm in close proximity, I need Cipro. Shaking his hand, I do not need Cipro. Being around him enough to walk through a sneeze cloud or something, I need Cipro. The second thing is, you need to ask, because you're gonna get called on this, and if you have kids, the school is going to tell you there's a case of meningitis in the school. You decide whether or not your child needs prophylaxis. But the thing you have to know is, what was the organism, what was the causative organism in that case of meningitis? 90% of the time, it's a virus. You don't need to do a thing. Only a few percent of the time is it going to be Neisseria. It could have been strep pneumo or something else. The only one you need to prophylax is Neisseria. That's the only one. So I told the student, I said, well, if you don't know what the offending bug was, is the guy at home? Did they send him home, or did they admit him to the hospital? Because these people will always be admitted to the hospital. Okay? So those types of things you have to know in order to give advice on what to do with this person. Let's see here. Complications of meningococcus. Name something bad, and there you go. Encephalitis is a direct infection of the brain itself. And most of the time, that's going to be due to a virus. And the viruses that are most prone to that are herpes, measles, and in the extremely rare case of rabies, and that's why rabies has such a high mortality. And then West Nile, that's just now starting to hit Oklahoma. And then HIV is quite common. Polio, thank gosh, is almost gone. The measles and the polio you will probably never, ever, ever see. But once you get outside of the United States where people don't vaccinate, you will see. And the sequelae from those types of viral encephalitis. And CME can affect anything. And most people, by the time you're your age, have been exposed to CMV, not CMV.
Is it rubella one of those two? It's not on the, I thought rubella was one of the ones that cause encephalitis.
In utero more than ex utero. Okay? And then bacterial and spirochete, there you go. The features of encephalitis are the same as with meningitis, with one exception, and that is mental status issues. You're going to have more focal neurologic signs with encephalitis, and not with meningitis. That's your thing, along with seizures. That's a seizure is a focal neurologic sign. How you diagnose it is essentially the same. You treat it the same. That's basically it. Encephalitis, the mortality is quite high, obviously. Here's a case, you see that nothing but pus around these deep brain structures here. This would be really surprised if that person lived. Not many people are going to survive encephalitis. Supportive care, that's what it's telling you. Supportive care. Give them oxygen, give them pain medicine, keep them fluid, keep them hydrated, make them comfortable. Treat the cause if it's bacterial. or use acyclovir if it's viral, or do the HSV, and then just see what happens. The problem with herpes encephalitis is it produces a necrotizing sequelae. It essentially kills, the brain essentially dies. And you can see here, this temporal lobe versus that temporal lobe, how much of a difference there is between the two in this case of HSV. The treatment, if you have determined it to be HSV, and you can do that with a brain biopsy and assay. If you diagnose HSV, I mean, you can't do it, you know, but a neurosurgeon could, is to get them on IV acyclovir for a long time. Brain abscesses, we've mentioned, I think we've mentioned it before, haven't we? Talked about brain abscesses? They're due to all sorts of things. They can be due to specific trauma or penetrating trauma to the brain. They can be to endogenous spread from someplace else, either para location, or people who are IV drug users can wind up with brain abscesses. These things are pretty nasty. Headache is the presenting symptom in most of them, along with focal neurologic deficits as the abscess continues to grow. Fever is not a good indicator. Seizures will usually happen once these things kind of reach a critical size. But really, headache is your presenting complaint. The best thing to do, so early on, I hope you've already picked up, you're going to need the CT. If somebody comes in with a focal neurologic sign, they go straight to a CT. Somebody comes in with a headache, with these types of things, you go straight to CT. You're going to find it on CT or MRI really quick. They need to immediately go to a neurosurgeon because it needs to be drained and cultured, and they're going to crack the skull on this one, okay? The thing about abscesses here on CT that distinguishes them from other things is where it says a ring-enhancing lesion. That's the pathognomonic thing for a brain abscess. And you can see it, they look like rings here on this CT. On an MRI, you can actually see the ring-type structure related to it, so the ring-enhancing lesion on a CT is what you're looking for. The antibiotic, or how you approach this, depends on what the cause of it was. If it was something from your teeth or sinuses, you treat it one way. If it's from neurosurgical procedure, you treat it another. If it's a hematogenous spread, you treat it the other. And so that's what this is listing right here. I don't really think you need to go into that because, well, you just don't. Okay, you have a brain abscess, and a couple of people you're going to be on the phone with. One of them is a neurosurgeon. The other one is an ID person. You're not going to mess with a brain abscess. Seizures, though, if you wind up in Blackwell on your rotation with Dr. Sheward, and he's gone to Ponca City to have dinner with his wife, and I think he just got divorced. He did. He's gone to Ponca to have dinner. And you're in the hospital by yourself, and somebody comes in seizing. Once you get that seizure under control with IV Valium or something like that, then you're gonna get that CT pretty doggone early, right? And if it's due to a brain abscess, you better call Sheward, you better call the ID guy, you better call the neurosurgeon, and get them on a plane to Enid, I think is the closest place. Okay? By the way, Jamie Massengill, he mentioned that unholy triad. He ain't kidding. Yes.
Are you saying IV guy? I don't.
ID,
ID.
infectious disease.
Okay.
Yeah, sorry. I really caution you on, I want to emphasize that. The unholy triad is some type of opioid, even something as mild as Lortab. Xanax is he kept saying benzodiazepine. Xanax is the preferred one. It's hard to OD on Valium or Ativan. Xanax is the one that they're after. And Soma, carisoprodol, is a muscle relaxer that doesn't work. It's of the muscle relaxers, and there are about 10 of them, it's the least effective for true muscle relaxation. Muscle relaxers only work if you use it for less than 10 days. There's no indication for using a chronic muscle relaxer. And the reason they want Soma is because once it makes its first pass through the liver, it's converted to a drug called methylphenidate, which is an old-time narcotic that really throws you for a loop. That's why they want Soma and not Flexeril. It's the methylphenidate. So I wrote, in my entire career, I've written one prescription for Soma. I've had thousands of people ask for it, but I've only written it one time, and that was because it was on a weekend, and I didn't want to cold turkey them, and I gave them for like 3 pills to get through the weekend. But that's it. Never write for Soma, ever, and never write for Xanax. No reason anybody should ever be on Xanax. Unless your mental illness is so bad that you can't function in society because of your panic disorder. And you should only be followed by a psychiatrist if you're on Xanax. Okay? That's my speech. But those 3 together equal respiratory depression to the point of arrest. That's why everybody's dying. Here's a brain abscess, nasty little boogers. That's not going to fill in. It's going to be a hole in your brain forever. Neurosyphilis, we really kind of beat this thing to death here. So, for those of you with chancres, my goodness, go get yourself some penicillin. The thing about this, though, I haven't mentioned, I don't believe I've ever mentioned, is Argyll-Robertson pupil. Have we ever talked about Argyll-Robertson pupil? It's because it involves your nervous system, it messes with the pupillary responses to light and stuff. An Argyll-Robertson pupil will still allow your eyes to accommodate, but they won't react to light. It messes up the 3rd nerve. They'll accommodate, but won't react to light. And so the old-time thing about the Argyll-Robertson pupil is it's associated with prostitutes. It's like a prostitute because, the syphilis back in the day. A prostitute will accommodate, but they don't react to you. They're not going to fall in love with you. They'll accommodate you. Shelby knows what I'm talking about. So they accommodate, but won't react. So, okay. That's a board question. That'll be a board question, I'm sure. Ani, you look like you got a question. You good? Treatment for neurosyphilis is IV penicillin for quite a while, then you can convert it to IM on an outpatient basis. Remember this, and I mentioned it before, that the test for syphilis in CSF is only the VDRL. You can't do an RPR, it's only VDRL. And once you treat them, you want to follow that VDRL over time to make sure that the titer is coming down. Here's the last thing we want to talk about is crypto. Crypto is it's like a yeast. It's not a bacteria, but it's more like in the yeast family. This is an opportunistic bug that people, suppress people, especially with AIDS. I mean, the definition of AIDS, I believe, is when the CD4 count drops below 200. I think that, isn't that the definition of AIDS, when it drops below 200? So here you see people with a low CD4 count for an increased risk for this nasty encephalitis due to this organism. If you have somebody living under a bridge, who's been an IV drug user, who's been HIV positive, not taking antiretrovirals, and they come in lethargic, this is, you need to go down this pathway and consider what you're doing. The treatment for, what the diagnosis is, they take the CSF and they'll, when they do the gram stain, they can do what's also called an India ink stain. It's a black substance that will stain the organism in the CSF, in the sample that you have. An India ink preparation is something you have to ask for in the CSF exam. Okay, so if it's on your index of suspicion, if you've got somebody coming in that's HIV positive, I don't care what, if you don't know their CD4 count, it doesn't matter. If they're HIV positive, you get this. Okay, there's also a latex agglutination test that can be done on the CSF, so do that too. The treatment for this is not an antibacterial type antibiotic, but antifungal, anti-yeast approach with amphotericin B and fluconazole, itraconazole, that sort of thing. And we got through it, and so you have time for lunch now, okay?